Good morning. My name is Cynthia Comella. I am Professor Emeritus at Rush University Medical Center in Chicago. And it is really my pleasure to present you with an update of current and future botulinum toxins. These are my disclosures. Botulinum toxin really came to the forefront when Justinus Kerner described the fatty poison, so-called sausage poisoning, in his monograph in 1822. It came into clinical use based largely on the giants, Edward Shantz and Alan Scott, who first considered using it in humans. And from there, it exploded. As we all know, botulinum toxin is a gram-negative spore-forming bacteria, Clostridium botulinum. 7 distinct serotypes exist, which are pharmacologically distinct. There are also subtypes of these serotypes that are distinguished by genetic sequencing. Currently, only serotypes A and B are available commercially for human use, although other serotypes have been initiated as potential treatments in humans. The botulinum toxin complex itself, as produced by the Clostridium, consists of hemagglutinin and non-hemagglutinin proteins, as well as the neurotoxin. And here you can see in this diagram a picture of the complexity of the structure with different foldings and different domains. And when you look, the yellow is the complexing proteins. You'll see the heavy chain, which consists of a binding domain, as well as a translocation domain, with a total weight of 100 kilodaltons. And then you see the catalytic domain, or the light chain, which is connected to the heavy chain by a disulfide bond. Now, this is a fragile bond and can be broken quite easily by heating or by shaking. We all know the mechanism of action of botulinum toxin. This is the neuromuscular junction, and here you can see the vesicles of acetylcholine. Through the activity of the snare proteins, some attached to membranes, some in the cytosol, you get fusion of this membrane with this membrane and release of acetylcholine, hence muscle contraction. As we know, here's the botulinum toxin, which interacts with the peptide SV2. Let me start that one over. This is a schematic of the botulinum toxin mechanism of action. You're all aware of this, so I'm not going to go through it in any great detail. But as you can see, there is in the normal action, you can see that the botulinum toxin, I'm starting over again. I'm sorry, this phone has screwed me up. Now, this slide provides you with an overview of the mechanism of action of botulinum toxin. You are all pretty well aware of this and familiar with it. I will just briefly summarize. On this side, you can see the normal neuromuscular junction with vesicles of acetylcholine. These vesicles fuse with the neuronal membrane through the action of the snare proteins, some of which are attached to membranes, either the vesicle or the membrane, the end plate membrane of the neuron, and some which float free in the cytosol. Through the action of these snare proteins, one gets release of acetylcholine and thus contraction of muscle. With botulinum toxin, you can see the heavy chain and the light chain. They interact with the SV2 peptide on the membrane, and then they become packaged into vesicles. Now, the heavy chain, as I said, it has a binding component and a translocation component. And the translocation component is felt to develop a pore in the membrane with the release of the light chain into the cytosol. Hence, it acts as a zinc endopeptidase, cleaving these snare proteins, each serotype cleaving a different snare protein, or if the same protein cleaves it at a different site. So you can see these are pharmacologically distinct serotypes. By doing this, it interrupts the ability of these vesicles to fuse. You do not get acetylcholine release, hence you get the end effect, and in the neuromuscular junction, that's muscular paralysis. Now, botulinum toxins overall, as we just noted, especially in dystonia, interrupt neuromuscular transmission, which causes muscle weakness. So if you weaken the dystonic muscle, you can more normalize head posture and reduce pain. It's a local effect predominantly occurring in the injected muscle, although, as we know, diffuses beyond the muscle, which is responsible for many of the side effects that one can see from this toxin. However, central effects have also been described: a reorganization of the somatosensory cortex and others. So it's not purely a peripheral pharmacologic agent. Further, we know that it's reversible, with recovery of the neuromuscular junction in approximately 3 to 6 months. And here you can see that process occurring, the poisoning of the neuromuscular junction, and then sprouting from the neuron, these sprouts receding, and you get restoration of the original neuromuscular junction. Now, there are FDA-approved botulinum toxins for dystonia and other indications in the United States. And I'll run through these quickly. So onabotulinum toxin A was the first that we had in the United States. Abobotulinum toxin A was available in Europe prior to onabotulinum toxin. And then incobotulinum toxin A as well. These are all the Hall variant of botulinum toxin A. Remabotulinum toxin is the only serotype B. You can see that comparatively they are of different sizes. Incobotulinum toxin has no complexing protein, so you see just the molecular weight of the neurotoxin itself. The vial sizes are different for each of the types. This is important. So for example, if you're going to inject hemifacial spasm and only had 100 unit vials, which was the case at one time, you would have to throw away at least 90 units of the toxin because they are one-use vials. Storage is different, particularly for Inca, which can be stored at room temperature. Reconstitution, one requires unpreserved normal saline. Now, in this column, you see the FDA indications. So these represent the double-blind, placebo-controlled phase 3 studies that led to FDA approval. Having said that, we tend to use the A's fairly interchangeably. Type B is a little different. It's more acidic, more painful to inject, and sometimes we do not use that particularly in the face. Now, these are some of the newer botulinum toxins. So daxibotulinum toxin A does not have FDA approval, but it does have especially in the pilot data, a long duration of effect of up to 24 weeks. And this is due to the unique protein excipient that's highly associated with the toxin. Its current status is that phase 3 clinical trials are completed now in cervical dystonia, await publication as well as submission to the FDA. Botulinum toxin A is another Hall variant. Right now it is FDA approved for glabellar lines. It's equivalent to Onabot insofar as its dosing. And currently underway is a phase 2 clinical trial in cervical dystonia. They have completed recruitment, but they're waiting for patients to reach endpoint, analysis of data, and so on. And then there is also, very interestingly, botulinum toxin type E. It does not have FDA approval, but the unique part about E is that it appears to have a rapid onset of action and tends to act over a relatively short period of time. Right now, botulinum toxin type E is in phase 1 comparative trial. It's been completed. It was compared to botulinum toxin, and I will demonstrate that in a further slide. Botulinum toxin A from Comella Pharma is not FDA approved. It's interesting in that it's a different strain. It's the CBFC26 strain and is currently undergoing phase 3 trials in glabellar lines. Now, this just shows daxibotulinum toxin, which I noted previously to have a long duration. And this summarizes the phase 3 study, where patients with cervical dystonia were randomized either to placebo, Daxi at 125 units, or Daxi at 250 units. The primary endpoint was the average Twister score at week 4 and week 6. And you can see from this diagram that, in fact, both 125 and 250 were superior to placebo. One of the secondary outcomes was the median time to loss of over 80% of peak treatment effect. And here you can see for the 125 in pink, that loss was at 24 weeks. And for the 250 at 20 weeks. Now, this exceeds considerably what we usually consider the duration of effect for the other botulinum toxin type A's. Now, this is botulinum toxin type E. I'm starting over. So this slide demonstrates the phase 1 study that I previously alluded to, that is a double-blind comparison of botulinum toxin type A as abobotulinum to botulinum toxin type E in the EDB of healthy subjects. And you can see here with the toxin type E, this is weeks after injection. This is the compound, a measurement of the compound action potential, that within a day, up to 4 days, there is a really remarkable change in the compound muscle action potential. Not only that, but this effect wanes such that by week 4 to week 7, one is back to the normal compound muscle action potential. And this is in contrast to abobotulinum toxin A, which more or less represents what we think of as the profile of effect of these toxins. And you can see that it takes 7 days to achieve some benefit, but really maximizing at 2 and anywhere to 4 weeks following injection. So the onset is slower, and it follows up to week 12, and you can see this maintained benefit during this time, in contrast to E. Now, there are a lot and a growing number of uses for botulinum toxin. It has been used for neurologic causes, as well as non-neurologic causes, including pain, secretory disorders, genitourinary disorders, cardiac disorders, gastrointestinal disorders, and probably its longest list is in the cosmetic area. But you can see it's been applied to so many different disorders, which led Time magazine at one point to say how, botulinum toxin became the drug that's treating everything. But is this really the case? There is certainly benefit. We have shown this time and time again from the use of the botulinum toxins for a variety of different disorders. This is a study recently published in over 1,300 patients, which is looking at the long-term adherence to botulinum toxin treatment. So how long do patients stick with it? And you can see that they looked at many different treatment groups: cervical dystonia, blepharospasm, oral mandibular, hemifacial, and spasticity. And you will note that despite its efficacy, there is a considerable drop-off in adherence amongst patients with each of these disorders over the course, this is looking at treatment years, over the course of years. So it's not a miracle drug that will last forever. For some, it is the miracle drug, which they repeat for years and years and decades. But for others, there are other issues that lead them to discontinue its use. And this has been looked at in a few real-world registries. And both CD-Probe, Anchor CD, and Excitable have demonstrated that approximately 30 to 40% of cervical dystonia patients are lost to follow in registry studies. It has been further pursued as to the reasons, although there is much more work to be done in this area. But they include things like lack of benefit, primary lack of benefit, meaning no response even with the first dose. And this may be in some of the more complex dystonias, for example, or secondary loss of benefit, which can be due to immunoresistance, and again, perhaps a variety of other reasons. The occurrence of side effects is particularly troubling to patients. For someone with cervical dystonia who gets severe dysphagia, it's unlikely they're going to risk it again, if you will. There's also this concept of the yo-yo effect, where a patient gets injected, they have to wait a certain period of time, depending on the toxin, to its benefit, and then prior to the next injection, the benefit is wearing off. And this can be anywhere from 8 to 12 weeks prior to their injection at 12 weeks. So we call this a yo-yo effect, where there may be this peak of benefit, but it is not sustained throughout injection cycles. The cost of botulinum toxin, including the different deductibles and the co-pays that patients have to pay, can be considerable. And so for some patients, despite the fact that some of the drug companies have developed these mitigation processes where they're reimburse patients for some of these costs, but it's not inexpensive. Also include loss of employment days, having to hire babysitters. So I think cost is also a significant issue. Then there's the inconvenience. So in Chicago, for example, coming every 3 months to get injected means trying to get through Chicago traffic, hiring a babysitter, taking a day off of work. So it's not something you can just do at home. You have to actually come to the office in order for this procedure to be performed. And finally, there are the unrealistic patient expectations. So when people hear about botulinum toxin, they think about the Time magazine cover, and they think, oh, this can be, I'm gonna be cured, if you will, or treated sustainably for many, many years using this. And patient expectations can't always be met, which is likely to have also led to a lot of people discontinuing therapy. So in overview, botulinum toxins are very effective for focal dystonias and many additional neurological and non-neurological disorders. But it's not perfect. Patients stop receiving the therapy, and there's always got to be reasons. I've given you several, but I'm sure with really focused research, we would find out several more. The good news is there are newer formulations and serotypes in process of evaluation, and these may address some of these issues. And finally, the botulinum toxin molecule itself provides all sorts of different opportunities. For example, if one did not use the light chain attached to the heavy chain, but a different moiety to do a different function, one would actually be able to get that moiety, conceivably, into a neuron, into the nervous system, which I think is really one of the future opportunities for this very effective treatment for other disorders. So with that sort of whirlwind through botulinum toxins, I'd like to thank you for your attention, and I would be happy to address any questions you might have. Thank you.
Thanks, Cindy. That was really great. Thanks, Cindy. It was so great. I think we felt the need to repeat portions of it. But I'm looking now to see if there are any questions. I forgot to mention earlier that if you have a question during the presentation, you can actually put it in the Q&A at any time instead of waiting towards the end. At the moment, I'm not seeing any questions, but I guess I should ask the other panelists to see if they are seeing the same thing too, because sometimes our screens are not the same.
Well, Buzz, I promise I won't repeat myself over and over again. If somebody does ask a question, they're probably afraid. Oh no, she's going to say it more.
No, it was a great summary. I mean, you described the fact that the botulinum toxins work very well. There's lots of new developments because we recognize that maybe 40% of patients ultimately drop out for various reasons, and so we can do better. Here is a question I am seeing now from David Martino. Any idea on the different immunogenicities of botulinum toxin E in particular?
Well, I think that's a really good question because with its short acting, one would probably not be using it for dystonia, where you want actually a longer duration of benefit. So in fact, I think it's more intended for more limited use. So it's being looked at for wound healing, to prevent gaping, to prevent the muscles from pulling apart at wounds. It could be conceivably used as a way to test a pattern of injection before using a longer term type of, a longer duration type of toxin. But insofar as the specific question, I don't think that there has really been a lot of work done insofar as repeated injections of E.
There is another question coming in at the panelist level. Joel Perlmutter is asking, what about serotype F?
Well, serotype F was used. I mean, it was looked at by Paul Green and did not turn out to be as promising of a replacement for the longer duration effects that one saw with type A. So to my knowledge, type F, although still a possibility, is not being explored intensively for human use.
Great. I see that Tony Lang would like to make a comment about the short-acting type. Can we get Tony unmuted?
Yep,
Can you
he's
hear me?
unmuted.
Can you hear me?
Yes, we can. Go ahead.
Yeah, hi, everybody. Great talk, Cindy. I just thought I'd share one possible use that I've had a couple of times is patients with very severe dystonic head movements, for example, in someone thought to have cerebral palsy, who the orthopedic or neurosurgeon needs to fixate the neck because of progressive cervical myelopathy or other problems. And in the intensive care unit, we've been asked to try to limit the amount of neck movement that's occurring because they want more stability and better chance at healing. And in these cases, you're really worried about using doses that are going to compromise swallowing. So maybe in the short term, when they're on a feeding tube or whatever in the ICU, you could get away with using much larger doses, allow the neck movements to diminish substantially, and then not worry about the long-term swallowing consequences.
I think that's a really good point, Tony. To be using it sort of acutely in those acute type of situations. Thank you for your comment.